So we will start. Um Now, as the two, you all know the topic, diagnosing the temporomandibular disorders in a digital way. Uh, where the temporomandibular disorders are the vast topic, and it requires a thorough diagnosis, or first the thorough history and clinical examination, and should we should rule out a proper etiologic factor or a root cause, after which only we should uh, think or plan for some treatment with the temporomandibular joint disorders. Regarding temporomandibular joint disorders, there are very different schools of thoughts. So, before starting any discussion, I would like to take a view of this video. Uh, this will I will explain its relevance once the. Some issue the system is having. Moment. Sorry, there was some technical error due to the internet issue. As we have seen in the video, uh, as the eagle, we too also required to go through the process of unlearning and grooming of the old thoughts and the concepts, and then again go through a learning the new concept so that we are able to provide a quality and correct treatment to our patients. If we correlate the above story with the temporomandibular joint, the temporomandibular joint disorders are being a less explored field. We need to go through the process of learning the new objective concept with uh, unlearning of some new old unlearning of new or we can say removal of some older subjective concept which are no longer valid. So, without going into the detail of the anatomy, as most of you know about the anatomy, uh, that coming through with the basic overview, there is an glenoid fossa with a condyle in between which there is a disc, articulating disc, which is anteriorly attached to the superior head of lateral pterygoid muscle, then posterior to the retropiscal tissue. So, uh, that temporomandibular joint disorder, in this first, the joint TMJ is an unique joint. So why we say that it is a unique? Because it has some unique feature which with any other joint in the body does not have. So what these features are and why this joint is unique? The mandible is a bone which is suspended with a crossing the midline. The joint can perform rotational as well as the translational movements. So this is a three-dimensional movement. Also, the both joints. There are two joints, and these both two joints has to work simultaneously and in synchronization. And these both joints are crossing the midline, or we can say a single bone is there. That is a mandible, and end at the both ends, this joint is there. So this both joint has to work simultaneously to get the movement in the mandible. Also, the condyle of the joint comes outside the glenoid fossa during the functional movement. And one more important aspect of this joint is that it is lined with the fibrocartilage. The fibrocartilage is uh, has a power of regeneration. Rest all the joints in the body are mostly lined by the hyaline cartilage. Now, when the degenerative changes in the joint take place due to the any occlusal forces or any other thing, uh, the temporomandibular joint has an ability to get regenerated and get repair itself if the proper occlusal forces are managed or we get a balance between the muscles of mastication. Now, the TMJ function is in most of the TMJ functioning in most of the research is said to have a centric relation, or we can say the it generally works on the concept of explained. It is explained in terms of centricity, which is generally given by an orthopedician, which they apply to the other joints in the body. But that this concept is not applicable in temporomandibular joint, because if you see here routinely the any joint, there are the two surfaces, one maybe here as it is shown, there is a one convex surface and one concave surface. So in temporomandibular joint, the case is There is one concave surface, which is a glenoid fossa. Then comes a convex surface, that is an eminence, articular eminence, and then comes the another convex surface, that is a condyle, and in between this joint or the two surfaces there is an articulating disc. This articulating disc is attached to a superior head of lateral pterygoid muscle. Now, this apparatus of the joint helps it to have a rotational as well as a translational movement, as shown in this animation. But we should take into consideration that it has actually as a three-dimensional movement. So, to understand these terms, we use the we can use the terms such as yaw, pitch, and roll, which are used during the three-dimensional movements of the joint. Now, TMJ is does not stand for the temporomandibular joint only. In actual, the TMJ is a teeth, muscle, and joint. So, um, this all three things, that is teeth, muscle, joint, has to work in harmony. And if there is any change in one of the factor, it will automatically affect the other one. So all three has to work in synchronization. Now, these are the two famous statements from a popular book of Dr. Peter Dawson. When bone and muscle wars, the muscle never loses. And when the teeth and muscle wars, the muscle never loses. Now, according to this statement, it is we can judge that it is clear that muscles are dominant. But when it comes to a neuromuscular paradigm, the teeth dominate and muscle and joints accommodate. These muscles and joints are accommodated to a teeth dictated position. So the if we keep the occlusion happy, automatically the muscles and joint will be happy. Uh, the teeth, muscles, and joint. This all three forms the basis of a neuromuscular dentistry. Now, the motto of this neuromuscular dentistry is: if it has been measured, it is a fact. If it is not, it has been an opinion. So uh, we have to always we have something measured or objective thing, not on the judgmental, or we can say on a just supposition or an just an arbitrary thing. Now, what I have learned from my gurus of the temporomandibular joint is that uh, whatever we do in the dentistry, maybe be a aesthetic implant or crown and bridge dentistry, periodontal treatment, ortho treatment, or say temporomandibular joint disorders treatment. One thing is common to all of this, that is the occlusion, but it is the most neglected topic by the dentist. It is it the dentist's fault? No, it is not the fault of a dentist, but it is due to what they are taught. Our dental curriculum is lagging the importance in the occlusion. It hardly gives any weightage to the occlusion in the curriculum, and this scenario is common throughout the world. Then, whenever we say about the occlusion and TMJ, the this is a reaction of a routine norm or all the dentists. This is because they are not well acquainted with the occlusion. Now let's understand why occlusion is an important and also how it contributes to the pathophysiology of the temporomandibular joint disorders. Now, let's say you have done a filling or a crown in the patient's mouth, which has a high point, and this high point will cause the hyperactivity of the muscles, or we can say masticatory muscles, because our posterior teeth controls the muscles of mastication that we have always been taught. But how? How the teeth are controlling the muscles of mastication? So let's go through a small or basics of the neuroanatomy or pathophysiology for the muscle hyperactivity. In this diagram, you can see this is a diagram of a neural pathway. Our posterior teeth periodontal ligament has the mechanoreceptors which are connected to the afferent, and they are only the transmitting the signal to the peripheral nervous system, whose first synapse is directly inside the central nervous system, and this is the only peripheral nervous system in the human body which synapse first inside the human body. Rest all the peripheral nervous system first synapse outside the human body in the ganglia, and then goes to the central nervous system. So here you can see that there are green, red, and blue pathways. The red pathway here is showing the trigeminal nerve, that is, and this is a facial nerve. Blue one is a facial nerve. So all this signals coming through, or pathways of peripheral nervous system coming through the this facial and trigeminal nerve are first synapsing in the ganglion and then going into the central nervous system, except for the this green pathway. Okay. If we get it in the zoom part, we can see that green one, which is taking the signals from the pedial mechanoreceptors through motor fiber of the V3. So they synapse directly into the central nervous system at the mesencephalous nucleus, and then from there they pass on to the continues to the trigeminal motor nucleus. Now this trigeminal motor nucleus, if we even see here, this green pathway is controlling the muscles of mastication and many structures in the oral cavity. Uh, the main structures which are then again innervated to this trigeminal motor nucleus are muscles of mastication, tensor tympani muscle, cerebelli palatini, mylohyoid, and digastric muscles. Now, muscles of mastication, they create the occlusal forces. Now, even if we see the tensor tympani muscle, which contracts the tympanic membrane, uh, if the this muscle is also getting hyperactive, it will cause some features such as tinnitus or pain in the ear, which is causing the ear symptoms. Again, all the rest muscles, all this group of muscles help in the functions of the swallowing. So the swallowing mechanism is also controlled with the neuroanatomy of the teeth. So now, if this high point or interference sends signal continuous to the central nervous system, which in turn keeps the muscles active for a prolonged time. This causes the accumulation of the lactic acid in the muscles. Now, this is a vicious cycle where the teeth is getting in contact, it sends signals to the central nervous system, muscles are in response, it sends the signal to the muscles of mastication, and they work continuously. Now, due to this continuous working, there is a buildup of lactic acid in the muscle, which cause the muscle tenderness or the spasm of this muscle, and the cycles continue. So, to get rid of this cycles is always needed to be break. Now, uh, if we consider all this neurophysiology, uh, we can come to a conclusion that the 90% of all the temporomandibular disorders are myogenous in origin, or they are muscular in origin. Uh, Even if we see the temporomandibular joint disorders research diagnostic criteria and we follow its sequence, we can see that the group 1 is a muscle disorder, that is a myofascial pain, the muscle hyperactivity of muscles due to the occlusal interferences or peripheral parafunctional habits will first lead to the muscle hyperactivity, which will cause a muscle tenderness. Then it progress further and cause the spasm of muscle, that is the myofascial pain with limited opening. Now, as we know that the articulating disc is connected to the anterior part or superior head of lateral pterygoid muscle. Now, due to spasm in the lateral pterygoid muscle, it will pull the disc into the anterior position, which will cause the disc displacement and it will produce a click. So, again, it will cause the reduction with and it will not cause the initially it will be only clicking, and then it will cause the little limited opening, or we can say it will get locked, but mouth opening will not reduce. uh, Once this position is passed away, the disc get locks further and we are not able to open the mouth. The condition is called as a lock jaw. So, similarly, we can also see when if the condition progress further, the group it comes to the group 3, and in this the disc will get completely out of the joint, or get out of the articulating surfaces, which will lead to arthralgia, osteoarthritis, or mm, osteoarthrosis. That these are the degenerative disorders of the joint. Not only this, the muscles of mastication can also cause this much of symptoms. These are all the symptoms which are associated with the temporomandibular joint disorders. Now, even if you see that this also covers the neck problem. Neck problem because the occlusion is directly related to the cervical posture. Now, if there is any issue with the cervical posture, it will cause this list of neck problems. So, how does it occur? We will also need to understand, because it is an very important part. It is called a craniocervical mandibular connection. Now, all all the cervical vertebrae have a three-leg or tripoded connection. So, whenever this tripod relation is there in between the vertebrae, they get a stable contact, except one vertebrae which cannot form this tripoded relationship, because the occiput, that is the base of skull, and C1 moves is the one unit and rotate around the odontoid process of the C2. Because the C1 is rotated around the odontoid process of C2, it cannot form a tripod or a third contact, or third contact of this tripodation is not possible. for the C1. Hence, the only cervical vertebrae which is not tripoded is C1. And if we draw a line from the occlusal plane posteriorly, it connects to the inferior border of C1. So, this third leg of the tripodation of the C1 is the occlusion. Hence, the occlusal plays a direct effect on to the neck postures. You can also feel it. Just do a small exercise. Uh, First, keep your neck straight and try to feel the contact in the occlusion. You will similarly now bend your head downward and again uh, clench the teeth in the occlusion and feel the contact. This time you will feel different teeth are getting occluded in the different point. Similarly, move stretch your neck backward or head upward and left side and the right side. Every time you will feel that there are different points of contact of the occlusion in the different position of the head. This is because there is a change in the relationship of the cervical vertebrae. So this proves that there is a the direct relationship between occlusion and the cervical posture. So any change in the posture will have a direct effect on the patient occlusion, and any adjustment made to occlusion will alter the cervical alignment. Now, this is because the center of rotation of mandible is at the junction of C1 and C2 and not at the joint. And due to this movement of the mandible uh, affect the C2 relationship with the C1. So there is a fulcrum of the mandibular motion at the junction of C1 and C2. So when the mandibular is in the neuromuscular position, C1 is centered over the C2 in a proper alignment. But if the mandible moves backward or it moves right side or to the left side, this rotation or this alignment changes. So, the alteration of cervical posture by a neuromuscular clinician in their treatment of the temporomandibular joint disorders and craniofacial pain patient should always be accompanied by the assessment of and the treatment for the occlusal pathology. So, uh, this is an uh, uh, concept behind the occlusion and the cervical posture. Now, due to this change in the cervical posture, there is a effect called a cascade effect or a domino effect that will further lead to change in your body posture. So, your cervical posture, or we can say your position of mandible, is again a primary cause for the posture or posture for defects into the body, uh, which is the descending effect. That is due to the issue in the occlusion or in the mandible, the issue is moving downward. That is a descending one. Similarly, it will also have a anterior posterior shift as well as a lateral shift. Now, uh, there can also issue can also be a ascending one. Initially, we have seen the descending one, that is from upward to downward. But if the patient has a short foot in due to the trauma, there is a discrepancy into the patient's length of the leg. That can also cause the effect on the cervical posture, which can lead to malocclusion, or we can say temporomandibular joint disorders like condition. That for that, the patient should always be properly assessed. What is the actual cause of the issue? Is it ascending one or it is a descending one? Uh, Also, it has this change in the anterior posterior shift causes the forward head posture, and there is also direct relationship of the airway with the temporomandibular joint disorders, or we can say a temporomandibular joint. So the any change in the mandibular position can also give cause an obstructive sleep apnea like conditions. How it is related, it is an although a long topic, but this is a video where we can get you can get an idea of this in a short.
Airway and TMJ. The normal way to breathe is through your nose. As we grow and develop, certain things such as pollen, cow milk, and other variables can cause an allergic reaction, causing the lymphoid tissues known as tonsils and adenoids to become swollen. As the tonsils and adenoids become swollen, they develop into an obstruction for nasal breathing, and slowly mouth breathing begins to be the primary intake of air into the body. In order to breathe through the mouth, the lower jaw comes down, the tongue comes off the palate and settles on the lower teeth. Nasal breathing is the correct way for air to enter the body, and during nasal breathing, the tongue rests at the palate and the pressure of the cheeks is balanced by the tongue. During mouth breathing, the pressure from the cheeks is unopposed by the tongue. The oral system becomes unbalanced and results in the deformation of the upper jaw, creating a V-shaped arch as opposed to a correct U-shaped arch. This also produces an incorrect swallowing function. Upon swallowing, the tongue rests on the lateral teeth, hindering normal tooth eruption, causing a lateral tongue thrust. A constantly open mouth causes the incisors to over-erupt. The result is a deformation of the lower arch known as the bicuspid drop-off. The result of this deformation of the upper and lower arches is the presence of premature contacts upon closing, which shift the lower jaw distally off of the physiologic trajectory. The narrowing of the upper arch pushes the lower jaw back. This forces the TMJ condyle to shift distally while the TMJ disc shifts forward. Upon opening, the disc can shift onto the condyle to restore the TMJ's correct position, reduction of the disc, and then shift back to an incorrect forward position upon closing. This is what causes a reciprocal click. In addition, the muscles could be in a state of hypertonus or spasm, which can result in tension headaches. An incorrect position of the lower jaw can result in parafunctional activity of the muscles, such as clenching and grinding. Over time, grinding can result in severely worn down teeth. As a result, the teeth become even shorter, the lower jaw shifts distally even further, and the vertical of the bite decreases. In time, joint degeneration occurs. The joint becomes deformed, and the ligaments of the joint become damaged. As a result, the TMJ disc can get trapped in front of the condyle. While the click may go away, limited mouth opening will occur. A distally shifted jaw and tongue positions result in even further restriction of the airway. In order to open up the airway, the neck moves forward and the head tilts backward. This stresses the spine and fatigues the neck muscles, which results in neck, back, and shoulder pain.
So this video shows the relationship between the airway and the temporomandibular joint. Now, if there are so many of the factors we are talking about, occlusion, muscle, joint, airway, what about the stress? Uh, there are many researches or few groups of people which we called biopsychosocial group of people who says that temporomandibular disorders are mainly due to the stress. The stress has role in TMD, but it is never primary. It is an adjuvant, or we can say it is more related to the adaptive phenomenon. How? Now, as we know, human body is highly adaptive. Due to this adaptation phenomenon, we do not have symptoms, but signs are always present. In temporomandibular disorders, important symptoms are pain and clicking. But if there is no clicking or pain present, Does it mean that the problem is absent, or there are no issue there? This is because the symptoms are subjective. Just take a simple example that patient is having a coronary artery blockage for years and he may not have any symptoms. But does it mean that he is a normal? He will have a signs which are generally ignored, and this can be confirmed with the help of the objective investigations such as blood investigations, ECGs, angiographies, and all the other different types of investigation. Similarly, in temporomandibular joint disorders, the symptoms may are many times are not seen, but signs are always present. Example: it can be in form of malocclusion, atresion, narrow arches, forward head postures, and many more. So, for which we need to do a diagnosis, which is an objectively with the help of the objective confirmations. So, here we can explain it more easily with the help of this glass. This glass, which represents the body, the adaptive capacity, or we can say physiologic limit, uh, limit such as and it is represented by the physiologic limit. Now, the issues such as malocclusion or bad bite, which are present in the body, get adapted by the body. Again, there is an addition of bad postures and parafunctional habit. Now, when the stress is added to this, all the part, what happens? There will be overflow of the glass. That is the it exceeds the adaptive capacity. Now, when this adaptive capacity occurs, we see a subjective symptom such as pain, or we can say clicking. So, uh, we need to understand that the stress is causing the is one of the factors, but it is not a major factor. Now we know that it is a multifactorial, and the question is most of the doctors or patients that okay, the stress is not factor, there are multiple things such as the occlusion, muscles, or the issue maybe with the joint or cervical posture. But what is the treatment for that? But wait, you don't have to jump to the treatment, because being a multifactorial, first you need to go through a thorough diagnosis. You first need to confirm the diagnosis about the exact root cause of the problem. So, if we jump to the direct treatment part, or if we say that if any TMD patient, I will give a sprint, I will give a muscle relaxant, anything without a diagnosis, it will lead to a failure of your treatment. So, even occasion says that the most common cause for the failure of treatment is not the quality of treatment, because as a dentist we are trying to provide the best treatment that we know, but the failure is generally due to the incorrect diagnosis, because we fail to first find the exact etiology of the any issue, we fails to diagnose it. Now, this can be very easily explained with the help of this diagram. How? We will just go through this. Sorry. Uh, Now, in this diagram, you see that there is an elephant and six group of people who are examining the uh, problem with their own perspectives. Okay, we consider this elephant as a temporomandibular joint disorder. And these six people are six different doctors, or which are trying to assess the problem with their own perspective. Now, coming to, if we say this first person, the first person is an ENT, which is checking the ear and says the issue is with the ear and you have a problem due to the ear issue. Similarly, the second doctor, he also is an ENT, but he is looking after the trunk, which can say represented as a paranasal sinuses. He says the issues may be with the paranasal sinuses. The third doctor is you or me, that is a dentist who is looking at the teeth and is considering that teeth is the main cause for the this disorder. Similarly, fourth doctor is representing the orthopedic surgeon who is looking after the joint and say the issue is due to the instability in the joint and due to which the pain or issues has been occurring. The fifth doctor is MD medicine who says there is a issue with the levels in your body, vitamin D levels, this levels, that level. There is something can called chemical locha, but we want to treat it with the help of the medication. And the sixth doctor, the last doctor, he is a psychiatrist and says that this issue is due to the stress. But now it is time that this all the doctors, group of doctors, should remove our blindfolds and see the entire elephant. It is not a single point issue. The issue is a multifactorial, and we need to treat this condition holistically or in a group manner. So, for which we require the thorough objective diagnosis. Uh, how we will now do or come to a exact key diagnosis? For that, we must require some objective investigation, and here comes the role of the biometric equipment. So these are the different biometric equipments such as T-scan, joint vibration analysis, electromyography, then jaw trackers, and ULF10, which we use for the objective biometric assessment. So the diagnosis is always key to a success. First, we take a thorough, comprehensive history, do a thorough clinical examination, and then we do investigation. Now, I being a oral medicine uh, specialist, or even when you must be in your academical years, you must have been taught that first take a thorough clinical history, then we do a clinical examination and come to a clinical diagnosis that we called a provisional diagnosis. On then we also form a list of a differential diagnosis, and then we do a objective, or we can say different investigations such as blood investigation, radiographic investigation, and whatever investigation, and we rule out the differential diagnosis and come to a final diagnosis. Similarly, in temporomandibular joint disorders, these biometric equipments are the investigative equipments for the diagnosing of the issue. Even CBCT and MRI, these are the biometric equipment, or we can say biometric modality only, where we are seeing or we can measure the pathology of the problem. Now, if we start with the biometric evaluation after clinical history and examination, uh, first thing we will assess is the joint. Now, uh, Generally, what we evaluate in the joint is the position of the disc, for which most of the time the magnetic resonant imaging is preferred. But it is not practically possible to get the MRI done in each and every case. Maybe due to time factor. Also, important factor is an economical factor. The economical factors, the cost of MRI is uh, much more higher, and not all patients can afford it. So the joint vibration analysis is a simple, non-invasive, accurate, objective measurement system, which can we can assess the joint, or in this assessment, we can assess the disposition of a joint on the basis of Piper's classification in matter of just minutes. It is a very simple equipment. In the picture, you have seen a girl who is wearing equipment like a headphone, and it is placed onto the condyle of the temporomandibular joint, and the patient is asked to open and close, do a functional movement, and during which we record the vibrations. How the joint vibration analysis operates on a very simple principle of motion and friction. If two surfaces, smooth surfaces, uh, rubs against each other, there not will be any vibration present. But if the surfaces are rough, it will cause a vibration. Now, it works on the principle that each temporomandibular joint pathology has its own unique signature vibration. So, here in this clipping, you can see that there is a normal joint, and the two smooth surfaces are moving against each other with the help of a disc, and there is no vibration present, which can be seen on the this graph. Here, this is a vibration of the right joint, and this is a vibration of a left joint. This is a complete JVA trace of a normal joint, where we can see right joint, left joint, and this wave represents the opening and closing path. Upper is the close and downward is the open. So whenever patient open and close, during closure, when the teeth get in contact, there's like a tuck in and get connect hitted against each other, it will cause a vibration. So this is uh, in this image, you can see there are no vibration in between the functional movement, that is the opening and closing of the uh, opening and closing motion of the jaw. So the joint is normal. Similarly, now if there is an anterior disc displacement with reduction, here we can see that when the condyle opens, the disc reduces and comes to its position on the condyle with a click, and again when the joint condyle moves back, the disc again get displaced, causing a click. So uh, during this movement, there will be there are two click present, so it will cause a opening and opening vibration as a closing vibration also. Here we can see that there are two different joints. In right joint, there is only a opening click, and there is no closing click. Okay, so in the left joint, there is a closing as well as opening click. Both are the present, opening and closing. Okay. So this is a small closing click and a little larger opening click. So here we can say that there is a anterior disc displacement with reduction with opening and closing click. Uh, Not only this, But if we choose any other diagnostic modalities which are subjective one, the accuracy is very questionable and it's very low with the different subjective modalities. But if when it comes to the joint vibration analysis, the accuracy is extremely high, right from around 88% to 100% in diagnosing most of the conditions of the joint or different types of disorders. So JVA interpretation is just easy. We are asking few questions to the patient, and after that we take the tracing. JVA open close tracing is done. After which we get few values on the software. These are integrals at few frequencies, amplitudes, and few technical data, which we feeds into this JVA flowchart. Here you can see we record the deviation, deflection, maximum opening, and all. We can compare the. We follow here the values from the uh, previous table what we get, and according to which we comes to a one of the diagnosis. So, and according to that, we compare this waveform into the patient's waveform, and we get a diagnosis, get a position of a disc according to the Piper's classification. Uh, the Piper's classification is denoted by 5 digits: Piper 1, Piper 2, Piper 3, 4, and 5. So, in Piper 1, the joint is normal, the disc is completely into the place. Uh, Piper 2 is also normal, but there is just a ligament or a little cartilage damage, but disc is not been displaced, it is in the position. In Piper 3, there is disc displacement or disc subluxation, which may be with reduction or without reduction, which is further denoted by A and B. So here there is a 3A or 3B. Then coming to the Piper 4, it is a complete disc dislocation with reduction and non-reduction. That is 4A and 4B. And Piper 5, when the disc is completely out of the joint and there is bone to bone friction, and it may be 5A, 5B according to adapting or adapted. So we get a proper position of a disc. So with help of this simple investigation, we can get the assessment of a disc position, which for which we generally do the MRI, which is a time-taking procedure and a costly procedure. The cost of this investigation would be much less. We can say almost one fourth the cost of the uh, MRI. Now, after the joint analysis is done, or joint examination is done, we comes to a occlusal analysis. We analyze the occlusion. But before starting with the occlusal analysis, what type of occlusion are there? What are the classifications of the occlusion? Most of us occlusion means is a class 1, class 2, and class 3. That is a static occlusion. But it is important to know about the other classifications such as the functional classification. It is why it is important to understand, because it is it helps us to understand the pathology or etiology behind the temporomandibular joint disorders, uh, where the occlusion is a playing role. So the functional occlusion are again of a two types. First one is a mutually protected occlusion, or we call it the canine guided occlusion, or we called it as a anterior guided occlusion. and second one is a group function occlusion. Now, for the occlusion, we need to get, if the research has proven that the function in the functional occlusion, the mutually protected occlusion is an ideal occlusion and should be target to be achieved during all the treatment modalities, such as where we are doing a occlusion correction, such as we are doing a full mouth rehabs, we are giving multiple crowns, or we are doing orthodontic treatment. The end result should be a canine guided or a mutually protected occlusion. So first we will understand with the help of this animation what actually is a canine guided or a mutually protected occlusion is. Here you can see that during the lateral excursive movement, the canine is helping to lift the posterior teeth and getting disengaged during the excursive movement uh, on the both working as well as a non-working side. So this is important to understand that there should not be any posterior interference when we are doing a lateral excursive movement. The posterior teeth should get disengaged immediately, and there should not be any occlusal interferences or parafunctional contact. So now, even in the occlusion, there are different schools of thought or different philosophies are with there. But even there is a difference in their thought, or most of them are have come to a consensus on the force and timing of the occlusion. Now, what are these consensus? All the teeth should come in contact at one point of a time. The occlusal force on right half and the left half should be equal. The posterior tooth should have a higher forces than the anterior forces. Uh, the counterpart should be higher on the posterior part, and the counterpart of every tooth should have a equal force. So, how you will judge this force? Because uh, all the experts are talking about the occlusal forces, but there is a complete absence of an objective occlusal measurement. It seems to be more guesswork, and the accuracy of this judgment is questionable because we are using a very subjective mode of subjective modality to measure the occlusion. So now how we are generally measuring or diagnosing occlusion in our routine practice? We are using the articulating papers, and we are been taught that when there is a big bite mark, or there is a high intense color of a bite mark, or there is a bullseye, these are the high force point or occlusal interferences. But do you know what are the actual accuracy of this occlusion paper? This I am talking about a standard occlusion paper, such as occlusion paper of a Bosch. The occlusal paper accuracy for the judgment of force is less, not more than 12 to 13%. This is an research oriented. So do you think this much of accuracy is sufficient, and from where this occlusal subjective occlusal measurement system has arrived? I would like to tell you that this concept of diagnosing occlusion based on the articulating paper, just what I'm talking about is the occlusal force, intensity of force on the teeth with the help of articulating paper, is not at all published anywhere in the literature. Okay. So the literature that proves that the accuracy is not more than 12 to 13%. These are the two studies which are proving that the accuracy of articulating papers are very low, and most of the people who are involved in this study are the senior prosthodontists who are more supposed to be expert in judging the occlusal forces or occlusal contact. Now, if the accuracy of this or subjective measurement modality is such low, can we depend on this articulating paper for judging or judging the occlusion for the full mouth rehab or orthodontic or implant? The larger treatments which we are doing on the patients, and we are all charging almost in thousands to lakh for the patient. Okay, so this will low accuracy articulating papers are not at all useful in judging such important factor. So how we measure it? We measure it with the help of the this T-scan digital occlusal analysis system. This is an handle of a T-scan, the Novus digital occlusal analysis system, to which this green part is a sensor on which patient bites, and this sensor maps measures the occlusal forces based on the pressure mapping system. Now, this is the occlusal in the software interference of the T scan, where you can see these are the occlusal contacts. This is an maxillary arch. Here we get the force according force percentage or force intensity in numeric form, as well as in the 2D color and a 3D color form. This is the force legend. Here the dark blue color represents the light force, and as this color change according to this legend, the pink is the highest point where there is a highest force. So if we see here, we can see that there is a high force in the 1/8 region. Here we can also see there is a right left percentage given. So here we can judge the right and left occlusal forces, as we have seen that the consensus about the force and timing. Here we can measure the occlusal forces. Right and left occlusal forces balance can be seen. This graph or this analysis is taken into the maximum intercuspation, which we call the multi-bite. We ask the patient to bite in the continuously for at least 3 times, so that the patient get a proper bite over the sensor. Now, here you can also see there is a graph showing a force percentage opposing to the time. So, we can analyze this occlusal contact according to the time also. This occlusal analysis system helps us to analyze the occlusion in 300 part of a second. That is like just like a slow motion movie, which is a first point of contact, and its next every respective contact, followed by when there are the teeth are gets into the maximum intercuspation, and when teeth start disoccluding, that is disengaging, and when the complete teeth are getting disengaged. So here on the graph we get the detailed timing. Similarly, we can check it into the lateral excursive or the functional movements also. Okay, initially was static. This is a function. This is an right lateral excursion, and when during the lateral or lateral movements, or we say canine guided movement, we say that there should be immediate disocclusion of the posterior teeth. So this disocclusion time with the help of research, Dr. Robert Christine has come or done a research and come to a conclusion that this disocclusion time should be less than zero point 0.4 to zero point 0.5 second. If this disocclusion time is prolonged, it will cause a more muscular hyperactivity. So here we can measure the disocclusion time. Here in the graph you can see four black vertical lines, A, B, C and D. What are this? A is a line which shows the first tooth of contact, when first tooth come into the contact. B is a point when almost your maximum intercuspation has reached, and the distance between B to C represents the maximum intercuspation, and C is a point when you start the patient start the disocclusion, and D is a point where the there is complete disocclusion of the posterior teeth. So with the help of this, the time between the C and D, that when the patient start the disocclusion and the posterior teeth are completely disoccluded, this is the disocclusion time. So in this we can see that patient is having 0.41 second, which is an little optimal but not accurate. The ideal time should would have it, this symbol would have been uh, green if this timing would have been less than zero point 0.4 second. Even the occlusal timing is more, it is a zero point 0.5 second, which needs to be a lower one. Also we can, if we see there is an quadrant wise, four quadrants are given here, we can see quadrant wise force distribution also, and this red line or kite shape structure shows the force trajectory, which helps in giving the direction of force, how the force is being, center of force is being traveling. Similarly, we can see it in the left lateral excursion and right lateral excursion. Now we say that muscles are controlled by the teeth. So how the teeth are controlling the muscle, or what are the effect of occlusion on the muscle? We can also do that, for which the tech scan has integrated its T scan system with a electromyography, which helps us to tell the effect of occlusion on the muscular activity and in the real time. Okay, it's just at the at what point of time or which interferences are causing the hyperactivity of a muscle. This can be explained more in detail in this. You can understand in this video, where the there is the first point of contact. The occlusion is started. Now the patient is getting into the maximum intercuspation, and during this maximum intercuspation, we can see, we'll pause it here, we can see the force balance. Now the force balance, patient is having 60 to 40% force ratio. That means the patient is having more occlusal forces on the right side than onto the left side. So do you think it is acceptable, or would this be an ideal force balancing? This will again lead to hyperactivity of your right muscles, which we can see here due to the, as if we compare, if we see the electromyographic graph, we can see the four graphs or four level lines of vibration. The upper one is a temporalis muscle right, second one is a temporalis muscle left, third is a masseter muscle right, and this is a masseter muscle left. Now if we correlate, we can see there is a more force on the right side. Similarly, the right temporalis muscle is more hyperactive as compared to the left uh, muscle. So this is again a diagnostic uh, point where we can uh, do the occlusion, which can help us to do the occlusion correction. Now we continue this video. Now in this forward. Now the point C, the disocclusion is started. Patient is doing a lateral excursive movement to the right side, and during this right excursive movement, there is a one point where now you can see this is an high occlusal force interference. Okay, this is an high occlusal force interference during the right lateral movement, and if we correlate with the EMG graph, the point when this interference has started had lead to a increase in the muscle activity into the right temporalis muscle. So this interference on the right is causing the hyperactivity of this temporalis muscle, and we can see that there is an increased disocclusion time. The disocclusion has started somewhat about 3.6 and it has been ended at around 5.6 or something. So it is greater than 1.5 seconds. So this is an high disocclusion time, and this is causing the muscle to be fatigued and getting muscles hyperactive for a prolonged time. Now, even if we see here, when the teeth were not in contact or when the occlusal contact is yet to be started, even then the muscles are here little masseters are little hyperactive, or there is a continuous activity seen in this muscular EMG graphs. So this helps us to bring to the conclusion that it is causing a there is a muscular hyperactivity even at the rest. Now, this importance of this electromyography, not only in, we can say, in the along with the occlusion, but even in the functional on the resting movements, we can use this electromyography for assessing the muscular activity. Here we are seeing a 8-channel muscle graph where there are 8 muscles, that are the 4 pairs of muscle: temporalis right left, masseter right left, sternocleidomastoid right and left, digastric right and left. So this graph or this electromyography recording has been taken while the patient was sitting in the rest position with all his teeth uh, were not in contact. That means patient mandible was in the physiologic rest position. So here we can see that even in the resting position, the temporalis muscles are active, while masseter muscles are also slightly active. Now, in the rest position, ideally, all these 4 pairs of muscles should be in the resting phase. There should not be uh, there should be all very least electrical activity present. If we see here, there are the values given, which few are shown in the green, few are shown in the yellow, and few are shown into the red one. Now the green one shows that they are in the resting or good, the activity of muscle is a normal. Yellow shows that it is little slightly hyperactive, while red shows they are highly hyperactive. So we can see there is an hyperactive temporalis, masseter. Sternocleidomastoid muscles are at the rest, but digastric muscles are also hyperactive. Now, when the patient is in the resting phase, the digastric muscle should also be in the non-functional mode. But if this is non-functional mode, we can come to conclusion that the patient mandible is not into the actual rest position, but is somewhat retruded. Okay, the patient is having little retruded mandible, which is causing the load onto the muscles, temporalis muscles, because the mandible, the temporalis muscle is holding the mandible, which is connected at the coronoid process, and the anterior belly of digastric, uh, which is pulling the mandible backward into the retruded position. The muscle is in the active form. So we can come to a conclusion that this is an retruded posturing of the mandible. So this is in the resting form. Similarly, we can record the EMGs in the functional forms such as clenching and swallowing. This electromyography shows that while clenching, the masseters and temporalis are active. It's okay. There should be a higher activity during the clenching, because when the temporalis and masseter will clench, then only when the teeth are clenched, this temporalis and masseter will be in the very high muscular, will have a high muscular activity. But if you observe here, the right and left temporalis muscle activity, right temporalis muscle is less hyperactive than the temporalis left temporalis muscle. Similarly, even the masseter, right masseter is slightly lower, but it's okay. It is an optimal difference, is not that much. But also the digastric muscles are having little imbalance between the right and left forces. But main difference we can observe is between the right and left temporalis muscles. Now this can be indicative that the patient have some issue on the right side on the joint, because of which patient is not able to clench properly on the right side, and the muscles are not getting into the proper functional activity. So in this way, we can similarly also examine the swallow function, and we can check the muscular activities in the resting as well as the functional movements. These electromyographic activities can also be helpful for the orthodontist while doing the ortho treatment. If before starting the ortho treatment, or while continuing or ending the orthodontic treatment, we can have this check this electromyographic activity, and check that is the occlusal balance functionally, clinically. Many times the occlusion is seen in a good form, but functionally its effect on the musculature should also be studied, because if there will be a imbalance in the function of imbalance in the muscles, it will leads to the creating high occlusal forces, which can also cause the relapse of the orthodontic treatment. So this is one more utility of the electromyography machine, which we can use for the diagnosing part. So this is an picture showing how the electromyography machine is seen. These are the electrodes. Here are the electrodes which are attached to the muscles. This is attached to a temporalis, masseter, digastric muscle, and a sternocleidomastoid muscle, and these all are connected to this amplifier box, which is connected to a system. So Now we have seen that we have examined the joint, we have examined the teeth, or that is the occlusion, and we have measured the occlusion, we have measured the muscles. Now this all three, teeth, muscle, and joint, that is we all three parts which we have measured help us to get a proper diagnosis and guide us in formulation of the treatment plan. We can find out where actual cause of the disorder is there, and according to which we can formulate our plan. And even during the treatment plan, whatever the philosophy you are using, it may be a occlusal splint, it may be a DTR therapy, it may be a neuromuscular approach, any approach, but we need to assess that is it going in the right path, because if it is not going the right path, it can also cause damage to the joint. So with help of this biometric equipments, we, this will guide us for the proper giving us a proper thorough finding etiologic cause of the problem. Similarly, this is one more modality. We called it as a jaw tracker. It is an advanced modality which can be used along with this three biometric equipment, which help us to assess the mandibular range of movement and find a actual neuromuscularly relaxed position of a mandible where actual physiologic rest position should be. So it helps us to measure the mandibular range of movements. This is the jaw tracker, with the help of which this mandibular range of movement is tracked. It is called a JT3D. Now, with this biometric data, this biometric helps us to diagnose accurately, formulate a treatment plan, analyzes the treatment progression. Now, uh, just go through, I will like to show you this small video clipping. Uh, I will why this is what is the relevance you can understand with this video.
It's just, there's this pressure, you know? And sometimes it feels like it's right up on me. And I can just feel it, like literally feel it in my head. And it's relentless. And I don't know if it's going to stop. I mean, that's the thing that scares me the most, is that I don't know if it's ever going to stop.
You do have a nail in your head.
It is not about the nail.
Are you sure? Because, I mean, I'll bet if we got that out of there.
Stop trying to fix it.
No, I'm not trying to fix it. I'm just pointing out that maybe the nail is causing.
You always do this. You always try to fix things when what I really need is for you to just listen.
See, I don't think that is what you need. I think what you need is to get the nail
See,
out.
you're not even listening now.
Okay, fine. I will listen. Fine.
It's just, sometimes it's like there's this achy, I don't know what it is. And I'm not sleeping very well at all. And all my sweaters are snagged. I mean, all of them.
That sounds really hard.
It is. Thank you. Ow!
Come on. If you would just.
Don't.
Try to smooth things my way.
So you can see in this video there are two persons which represent the two group of people. The first, the man which believes in the objective assessment of the measurement of the etiology, and the woman which represents the group of people who don't believe in this objective measurement, and they try to treat the disorders on the symptomatic basis. Now, once we know that what is the etiologic cause, or we get a proper diagnosis, now we can come to the treatment modalities Now the treatment modalities are various type of therapies uh, which we can decide. The disocclusion time reduction therapy, which we call the DTR therapy. Then comes the neuromuscular orthotic. It is nothing but an anatomic splint which we record in the give in the neuromuscular recorded position, and which helps us to reprogram the muscles, and which is then followed once the muscle is been reprogrammed and the patient is symptom free. We go forward to the second phase, followed with the help of a neuromuscular orthodontic, which is a guided orthodontic therapy. It is a newer concept in the orthodontics, and or else if there is not a sufficient tooth structure available, then we can go for a full mouth rehabs. And if there are some sleep related disorders associated with the problem, we may also need to provide a patient with the sleep appliance. Now we will just go through in short what is this therapies, because they are itself bigger topic to discuss. What is a DTR therapy? DTR therapy is it is just an, we can say, a neurological TMD treatment method, because here we are first measuring a force and time and its effect on the muscles with the help of electromyography. Then we are taking a doing a joint analysis, X-rays, CBCTs, MRI. We measure all this thing, and based on this measurement, we we do a occlusal corrections. That This occlusal correction will correct the muscular activities of the muscles, through a altering the neurological signals as the occlusal is affecting the muscles. So how do we do that? We do it in a digitally directed alignment manner, where we we create a immediate complete anterior guidance development. We do anomoplasty, in which we are just correct, correcting the occlusal interferences by changing the cuspal slope. It is just a correction of a microns. We are not grinding the tooth completely, but we are just changing the cuspal inclinations in microns, so that it will not create the interferences while doing a lateral excursive movements. And we will try to bring the disocclusion time below 0.4 second, which will reduce the muscular activity and resolve the problem. So next treatment modality, that is a neuromuscular approach, in which we do it in a generally two phase. In first phase, we use the ultra low frequency TENS. This is an different TENS than our routine medical TENS, which works on the low frequency, and it works on the antidromic effect, which is an patented technology. And these are the little expensive TENS machines. The routine TENS machines comes in few thousand, but this machine is costing somewhere between 2 to 3 lakhs, and only two companies are manufacturing it. One is Myotronics and one is the Bioresearch. So uh, the after doing a tense therapy, we relax the muscles, we check confirm the muscles are relaxed with the help of electromyographies. We check the joint vibration analysis, that the joint are in a good position, and if required, we do a jaw tracking. We check the mandibular range of motions, and then we record the bite. And in this bite, we provide a orthotic or a anatomical splint. And after placing the anatomical splint, we apply the DTR principle on that splint that we are doing. That means we are doing a micro occlusion corrections on that splint for balancing the occlusal forces. Now these are the images which are showing these are the type of the orthotics. The upper one is a resin orthotic which is tooth color, and lower one is an clear acrylic orthotic. So with the even after giving orthotic, if patient has a sleep issues, we give some type of sleep appliance. We may require neck alignments which chiropractors generally do. In India we don't have chiropractors, but very few chiropractors have been now started in India, but available in very few cities such as Mumbai, Bangalore, Delhi, which are but even nowadays the osteopath or physiotherapies has started doing this chiropractors, but they should be well versed with it. So after doing all this thing, once the patient is symptom free, patient all symptoms are gone, the clicking is gone, the pain is gone, and the patient is now completely symptom free, then we can move to the phase 2, where we do a permanent changes in the there that we build that position permanently into the by correcting their occlusion, because this position can be maintained. The muscles and joint are adapted in that position, so that it is a tit dictated position. So we do a guided orthodontic corrections, or if required, if tooth material is not proper, we can do a full mouth rehab. Even in some cases, a combination therapy can be done, where initially we do orthodontic corrections which are followed by the full mouth rehabs. Now, uh, and once this the neuromuscular stable position is occurred, the occlusion is happy, muscles are happy, and the joints are happy, and patient is completely symptom free. Now, the role of biometrics in orthodontics, it is also a critical part, because the orthodontists are people who are giving a good aesthetic smile, or patient generally seek them for a good cosmetic reason. But along with the cosmetic, it has to be always be confirmed that the occlusion is functionally also in a very good position. So the this biometric helps the orthodontist to measure the correct position of the occlusion, because theoretically even the orthodontic principle says that the end of orthodontic treatment, the occlusion should be in the canine guided occlusion. So clinically, or by doing a conventional method of mounting the cast on the adjustable or semi-adjustable articulator, it is not that practically uh, possible to check the uh, proper that we have achieved a proper canine guided occlusion. But this piece can help us to measure it into the real time that we are in going into the proper direction. Also, the electromyography helps them to confirm that the jaws are in a proper position, the muscles are in a harmonious position during their tooth movements. Because if there is some muscular imbalance present, it can also lead to the failure of treatment in future. So uh, uh, this biometric measurement is very important in orthodontic treatment. Even the myofunctional therapies given by the orthodontist are very uh, well measured with the help of this biometric equipment. Now, next thing is Biometrics in full mouth rehab. So full mouth rehab is one of the complex procedures we are doing with the help of building complete crowns or with the help of implants and crowns. But there also occlusal harmony or occlusal force harmony is important. If it is achieved properly, it helps the dentist to preserve their precious work, else it can lead to the damage of their occlusal work. Or also, if there is an imbalance in the occlusal forces, the patient may land in future for the some temporomandibular joint disorders condition. Now, uh, biometrics in implant. I think so. This all must be interested because implant nowadays is the most booming hot topic for the dentist. Everybody is loving to place implant, but while placing implant, we know that the most of the implants nowadays are prosthodontically driven implant. The prosthetic management or prosthetic design is a very important aspect of the implant. So when because the implant doesn't have a periodontal ligament, normal tooth has a periodontal ligament which get compressed when patient get into the occlusion. So we have to balance that occlusion so that the implant prosthesis is loaded in a delayed manner, not at the same time of the when the natural tooth is being loaded. So generally what we do, we I have asked many doctors how do they achieve the delayed loading. They say it is easy doctor, just place a crown little slightly under occlusion. But do you think it will solve a problem? It might solve a problem for a few days, but after a few days the opposing tooth will again get supra erupted and will may cause the interferences, which will again in turn will cause the muscular hyperactivity and lead to high occlusal forces, due to which there can be uh, high loading on the implant, or there can be bone loss, loosening of abutment, ceramic chipping. Uh, Bone loss is most common feature which I have been noted. The doctor has placed the implant very in a very good method. All techniques have been used properly. Prosthetic design is also good, but one thing lacks, that is a occlusal force loading time, which if that is not achieved properly, it will lead to failure of your implant. So this point is very important, and there is a nowadays special feature uh, added to the software of T-scan, which alerts if there is a early loading of the implant. When we denote the specific tooth as an implant and there is a high loading force on the that pontic or that implant, the software automatically gives a warning sign that your implant is having a high load or there is an early loading on the implant. So it can, you should adjust your prosthetic before doing that implant. Even before planning for an implant, it is necessary to get assessed the occlusal forces and occlusal effect on occlusal muscle. I had a similar case where my patient were already having crown in the lower 7-7, 3-7 and 4-7 were given a crown after a root canal treatment. Now, the patient's occlusion anterior guidance were completely lost and there were slight uh, high points onto the crowns. So, what happened? The both crowns were zirconia crowns. So the patient had fractured one zirconia crown cusp on one side, and on other side the patient had literally fractured his tooth vertically due to the force transmission from crown to the tooth. Now, due to this in such high occlusal loading, if we plan to give, now that vertical fractured tooth need to be extracted, it was extracted. Now restoration of that tooth was a second challenge. How we will restore that tooth? Now if occlusal forces are such high that it can fracture the tooth or fracture a zirconia crown, what can happen to a implant or what can happen even to a bridge. So in such patient, first the occlusal correction or the occlusal uh, balance was formed. We done a DTR therapy, we balanced the occlusal forces on that patient, and then we proceeded for the implant. And now the patient is having a proper occlusion. There is no issue with the even with the new prostate. It's almost more than a 6 to 7 months. Now the patient is completely okay. So for this helps us to tell know that it is very important to analyze the occlusion even before planning for the implant. So this is uh, if we balance this occlusal implant, it will prevent your failure of your precious treatment. So with this, I would like to conclude my topic that biometric equipments help us, the dentist, to eliminate the guesswork and diagnose the etiologic factors accurately and make the treatment planning in all the dental treatment. Precise, we get a precise dental planning. Also, it helps in improving the prognosis and making the outcome of treatment more predictable as everything is measured. We are measuring everything, so there should not be any issue. So uh, before ending, I would like to bring a fact to all the dentists that we should not only think for the general dentistry or occlusion with the help along with the general dentistry, we can take care of the occlusion, or we can say temporomandibular joint disorders. We can take care of postures, we can take care of sleep apnea. Along with all these things, we can take a care of a general well-being of a patient. So stop, we are not just a tooth doctors, but we are a proper physicians, which can where we can prevent the patients from landing into the systemic issues or other systemic problems by proper managing of the teeth, or we can say a occlusion. So I'm a member of a ICMO. I would, if anybody who is interested in learning about the more about temporomandibular joint disorders and the its effect on the body, this is a international organization where we group of doctors are uh, discussing and learning. These all people are open-minded people. We don't force anybody to follow any physiology, but we learn in more objective methods. So India section is also started. Anybody who like to join can contact me or search the internet. They can get the details of this ICMO. So thank you, and session